So hi everybody, I am Michelle Pittman. I'm from Fredericton, New Brunswick, Canada, and I'm going to talk to you a bit about my clinic and the services that all of our nurses provide. And I do have a lot of slides, so I'm going to be quick and really shuffle through these. So I do want to acknowledge that our clinic is located on the unceded traditional territory of the Wolastoqey, Maliseet, Mi'kmaq, and Passamaquoddy tribes. And for disclosure of interest, I just want to mention that I got a scholarship from INSU. I wouldn't have been able to make it to South Africa without it. And that I do get industry support, not for this presentation, but I just have in the last 12 months from AbbVie and Gilead. So the purpose over the next 10 minutes, I'm going to provide a comprehensive overview of the harm reduction landscape in New Brunswick, including current services that are offered at our facility, gaps, and opportunities for growth. And I'm also going to explain the innovative nurse-led programs that we also do. So this is just what RECAP stands for, but you guys can go to our website. So we have a tri-city model at RECAP. So this is Canada. And that's little New Brunswick, where we're from. And in New Brunswick, we have 3 major cities, Fredericton, Moncton, and St. John, and we have a RECAP location at each of those sites. And the plan is to actually expand further into rural and Indigenous underserved areas. So little arrows. And my clinic in particular is in Fredericton, which is the capital city of New Brunswick. So just some substance-related stats in New Brunswick. Toxicity, opioid deaths peaked for us in 2023. There was a slight decline in 2024, but we believe that this year will be the all-time high because even our city police force was mentioning that they were even running out of naloxone when they were responding to opioid toxicities. So even with stimulants and opioids, right now we're seeing a lot of crystal methamphetamine and a lot of fentanyl in our area. So 48% of opioid deaths were related to fentanyl in 2024. Apparently our hospitalizations remain stable. And naloxone kits, since 2018, they say that 9,700 were distributed, but I believe that it's gone way up. And the government keeps funneling more and more money to our needle exchange programs, and they can't keep up with the demand of handing out naloxone kits, and you can't get them for free in New Brunswick. You have to go to the pharmacy, pay $50 to $60. If you are Indigenous, you can get them for free, but the majority of the patients that we serve are not Indigenous, so they don't qualify for free naloxone kits unless they're able to get them from the needle exchange. So just some data here is just showing patients that actually received naloxone, patients who responded to naloxone, and then this also shows just from the coroner's office the deaths that we're seeing in New Brunswick per year. Opioids without stimulants, with stimulants, as you can see. So let's talk about RECAP. So who we are a nurse-led facility. I'm very happy to say that. So I'm a nurse practitioner there, and we have no other providers there. There's no doctors. So I'm the sole provider, and I'm going to talk about our demographics later, but we also have registered nurses, licensed practical nurses, PSWs, peer support worker, and our admin staff. And we strive to provide low barrier judgment-free environment that embraces meeting people where they're at. So I'm pretty sure I don't need to explain this to you all, but I like to explain when I do presentations that there's a continuum of substance use. Some people can use substances and have beneficial use, like all of us today, drinking espresso and coffee, or going outside for smoke breaks, or enjoying wine at the reception tonight. But where it becomes problematic is if it's interfering with your everyday life or relationships. So I just like to have that little explanation. So at RECAP, we offer medical treatment for opioid use disorder. So I provide OAT services to help people keep out of withdrawal. So I use things like methadone, buprenorphine, naloxone. I use SROM. And then I also use the long-acting buprenorphine injections that are monthly. I also run an injectable opioid agonist therapy, and I prescribe liquid hydromorphone to folks, and they can come inject up to 2 times per day. And to keep them out of withdrawal overnight, they go on a SROM or they go on a methadone. And just about IOT, It's actually a really small piece of our program. So we have about, I think, 30 participants right now. We used to have upwards of 70. We're seeing a large decline in injection use because people are turning towards smoking fentanyl. So I'm really hoping that the conference this week can help me figure out what I need to do for our fentanyl smokers, because our government is very behind in helping us figure out what we need to do. So I just want to figure out what we need to do. So yeah, I explained all that. So one of the things that seems to be a hot topic this year at the conference is stimulant use disorder. I'm really happy to say that I actually provide replacement therapy for stimulant use disorder with commonly prescribed ADHD medications or dopamine antagonists, because it has been proven that it reduces cravings for stimulants like crystal meth or cocaine. So I prescribe methylphenidate, lisdexamfetamine, dextroamphetamine, aripiprazole, and risperidone. And I typically save the antipsychotics for people that have underlying psychosis or for people that have stimulant-induced psychosis. All right, our patient demographic. So for all of our locations, and these numbers were from the summertime, so they're a bit different now. But in Fredericton, we have over 300 people on replacement therapy, and at the time, there was 38 IOT participants. In Moncton, we have 20 people that are on IOT, and that's pretty good considering that program only opened up in the spring. And in St. John, we have 29 people on IOT. And common misconception we get, we're not a safe injection clinic, so people can't bring their substances into our site and consume them. Everything is medically prescribed by myself for opioid and stimulant use. We definitely need a safe consumption site, but we just don't offer that service at our facility right now. I also offer primary care and mental health access, linkage to STBBI and Hep C treatment. I have a peer with lived experience that's on staff, and we connect patients to case management and to other services. We're lucky to have a community health center directly across the street. So if I have a lot of complex wounds, or if I need them to get a breathing test or to see OT, I'm able to get the peer or a staff member to walk them across the street to receive the care that they need. Nursing, outreach, and community events. So this is a big way to build rapport with our clients to get them in the doors. So we do weekly outreach. Our nurses will go out to different tent sites and try to find people that we've lost to follow up, and find new patients, and even just provide education. So I also do primary care and mental health access to external organizations. We have 12 Neighbors Community, which is the tiny homes, if anyone's ever heard of that. They have 100 tiny homes. And for over a year, they've never had anyone that was providing primary care, so I've been going there and doing that. And then we just do pop-up liver health or STBBI events. So this is our intake process. I'm not going to go through the whole thing, but basically our LPNs do the whole intake. Somebody can walk in off the street, and the nurse will just bring them into the room, do a urine drug screen, ask the comprehensive medical history, and then it's put into something called Huddle, which is something I review every day of the week. And I just figure out what replacement therapy is best for them, get them started, and then I get them booked in for a meet and greet with me. I typically don't schedule appointments for my patients. I just give them times that they can walk into the clinic, because I know that giving them an appointment time is disadvantaging them. And then the main reason why I'm actually here is I've started a nurse-led Hep C program with absolutely no funding. And it's just something I did off the side of my desk, which I'm sure many of you have also done. So back in 2021, just within our IOT cohort, and at the time I think we had 60 people on the program, but 90% of them had a positive Hep C antibody, and 70% of them had an active infection with RNA detectable. So we realized, holy crap, our program has a really high prevalence of Hep C and we need to treat it. But there were so many barriers in place. Like we needed fibrosis scores, we needed genotypes, they needed to go see an infectious disease specialist. So it was just so convoluted that I was just able to take it and run with it. And I had an infectious disease specialist that helped me with that. So in the process, I was able to get a gene expert machine. I started on Action Hepatitis Canada, and they helped me at the policy level to reduce all the barriers. So as I was reducing the barriers, you can see that our Hep C numbers drastically decreased. And I'm happy to report that as of This year, like a month ago, I pulled my numbers and I'm down to 2% with RNA detected. So I have one person on treatment because I've already treated the rest of them. So I'm pretty proud of that, and I'll be talking about that on Friday. So, I'm right at 10 minutes, okay. So just to conclude, harm reduction services in New Brunswick, they're really essential as they are everywhere else. There's trends in toxic deaths and hospitalizations. It highlights that there's a lot of continued challenges. And fentanyl involvement, I think that's one of my major barriers, is just the smoking of fentanyl and not being able to prescribe something that's really combating that for them. And we really need to continue investing into nurse-led models. No offense to any doctors that are in the room, but nurses can do it too. So thank you.